So we're here today on this sunny April 16th, 2014 with Leo Stolbach, and we're going to talk about your career in medicine, your first interest in medicine, and the numerous things you've done during your career and continue to do. So tell me, what first drew you to medicine?
Well, when I was a kid, 9 or 10 years old, I read a book called Microbe Hunters by Paul Decreef. And I was so fascinated by the way the scientific method led people to make breakthroughs in medicine. And I was absolutely fascinated by that. And I have to say that I think my mother was not disappointed by the fact that she was a good Jewish mother, by the fact that I was interested in medicine. And my parents really nurtured that belief, and so I eventually made it into medicine.
And you, as an undergraduate, you went to University of Rochester?
No, undergraduate I went to Harvard.
Oh, okay.
Yeah.
And what did you major in?
I majored in biochemistry.
Mm-hmm.
I did my senior thesis with a cardiologist at the Massachusetts General Hospital. And actually, during the summers while I was in college, I sort of wanted to confirm that that this was a field that I really wanted to go into. And I actually worked in a hospital in Westchester, New York, the Northern Westchester Hospital in Mount Kisco. And there I worked in the lab, in the clinical lab, drawing bloods. I learned how to draw blood. And I also did some Diener work in terms of assisting in autopsies.
Mm-hmm.
So that gave me a significant exposure. And then the following summer I actually worked at the Beth Israel Hospital in the hematology lab there.
Wow. So you got good experience. And about what year was this happening?
That would have been in 1956 and 1957.
Okay.
Yeah.
And then from there?
Oh, I'm sorry, 1953, 52 and 53.
Okay.
I'm a little ahead of myself.
The Eisenhower era. And you then went into medical school in Rochester?
Right. And again, during the summers we had off. And so during that time, I actually wanted to spend my summers in Boston for personal reasons. And I was lucky that I ended up getting a job in the cancer research lab at the Tufts New England Medical Center. And again, it's a matter of serendipity. The first choice for those jobs were Tufts medical students. And there was one that dropped out just at around the time when I came by, and so I happened to get a position there. Mm-hmm. The person I worked with his name was Bill Fishman, and he was an enzymologist. And one of the projects that I worked on him with was, at that time we were using acid phosphatase for diagnosing cancer of the prostate and following cancer of the prostate. And I worked with him on an improved method of measuring that.
Wow.
But the major research that we did was Dr. Fishman was interested in differentiating different types of alkaline phosphatase. And he had a test that separated the alkaline phosphatase from liver and intestine and bone. And this was all based on the heat stability of these three different kinds of alkaline phosphatase. And lo and behold, we got some serum from some patients that had a high level of a very heat-stable alkaline phosphatase. And So we looked into that further, and we found that the and these patients all had cancer. It turns out that placental alkaline phosphatase is heat stable, and we found that this ended up being a tumor marker that was quite reliable and was found in a variety of tumors. So initially it was called placental alkaline phosphatase, and subsequently there was a patient who had a very high level, who had lung cancer, and he died, and we were able to harvest his tissue and found high levels in the tumor tissue. And so we named it after him. It was called Regan isoenzyme.
Huh.
And so it was definitely a carcinoplacental marker that we were able to describe.
Exciting times. So what did, just out of curiosity, how much did it cost to go to Harvard? How much did it cost in those days to go to University of Rochester Medical School?
I think that at Harvard it was $400 when I started a year, and it went up to $600, I think, my either junior or senior year. And as far as medical school, my recollection is that it was something like $1,000 a year. A little different than
Today.
what it is today.
Right. So you went to the University of Rochester, mostly lectures, or what was the teaching like at University of Rochester?
University of Rochester Medical School was one of those schools that came as a result of the Flexner Report in the 20s, where they changed the whole structure of medical school. And it had a basic philosophy that I really admired. It was that if you're good enough to get in here, we're going to get you out of here as a physician. And there were a number of people who took a year off to do research, and it was a wonderful experience. The other aspect of it was that it really focused on taking care of patients in a humanistic way. And the faculty really gave you a lot of support. It was on our different rotations, we had the responsibility for the patient, and that was drilled into us. And I feel that it taught me the humanistic aspect of medicine and how to take care of patients well. The other aspect of it was that we had a psychiatry department that had 3 people who had their boards in both internal medicine and psychiatry. And they were doing research at that time on the psychological effects of disease and why people got sick when they did. They did 2 of the people did research in the cancer area, and we don't have time to go into that, but I'd like to just say that one of my idols was George Engel, who developed the term biopsychosocial model of medicine. He wrote an article in the late 70s in the journal Science, and I subsequently ended up going into the area of mind-body approach to taking care of patients, and I'd say that that was that was something that I formalized at that point, but I think my taking care of patients was based on the biopsychosocial model.
Now, when you trained, would you say that half or more than half of doctors went into general practice, or what percent would you say?
I'd say that at least 50% went
Yeah.
into general internal medicine.
And you chose to specialize, and you chose
Yeah.
to specialize in oncology. And was this because of your earlier experience?
Well, it was a combination of things. I did a rotating internship in Cleveland, and that gave me the opportunity to see each of the specialties. We spent 3 months on pediatric, 3 months in medicine, 3 months surgery and OBGYN, and 3 months in psychiatry. So I certainly had an opportunity to pick one of those fields, but I enjoyed all of them. So, but what happened was I applied for the NIH and got a position as a clinical associate at the NIH. And I actually, I'm sure that the reason I got that was because of the work that I did with Dr. Fishman at Tufts.
Mm-hmm.
And so that sort of determined what specialty I was going to go into, because I was in the endocrinology branch, and we were taking care of patients who had a very rare kind of tumor of the placenta called choriocarcinoma. And this was a fatal disease, 95% fatal disease. With the use of one of the early chemotherapy drugs, methotrexate, we were able to cure 50% of the patients who had metastatic disease.
Mm-hmm.
And by the time I left, with the addition of another medication, actinomycin D, we were able to increase the cure rate to 75 to 80%.
And my understanding is that choriocarcinoma wasn't that the first disease curable by chemotherapy?
Actually, leukemia was before that.
Okay.
In terms of some of the work that Dr. Farber did.
Ah.
Interestingly, using the same
drugs.
Using that drug, but that was preceded by some of the other alkylating agents. But it was very gratifying to take a disease that was that lethal, and to convert it into something that was quite curable.
Right. And what about a typical day during your rotating internship? What sort of hours would you keep? What sort of, diseases would you treat?
Well, it depended on what service I was on. We were on every other night, every other weekend. When we had a really sick patient, we would sleep on the ward, and we followed our patients closely.
Mm-hmm.
So,
were you married at this time?
no, I got married when I was at NIH.
Okay. And what interested you during a rotating internship to actually apply to the NIH? That certainly isn't the usual path.
Actually, you needed to apply. I think when we were when we got our internship, the requirement was that you had at least a year of internship and a year of residency. So I then went down after my first 2 years. I spent 3 years at NIH, and that served as my fellowship in oncology. At that time, there were no oncology fellowships.
Right.
Oncology was a budding field, and actually ASCO, the American Society of Clinical Oncology, was not formed until 1964, which is the year that I came up to Boston to take my first position out of residency.
Mm-hmm.
But after my 3 years at NIH, I had to go back to Cleveland to finish my residency.
Mm-hmm.
I had to do my last year of residency. I had gotten married in when I was down in Bethesda at NIH in 1961, and then my wife, and at that time my first child came, and we lived in Cleveland for a year, and our second child was born while we were in Cleveland.
Mm-hmm.
So,
And so how was all of this training on your family life? What was there any time to spend with your children?
what I what I sometimes did when I was down at NIH, it was a little easier because we had certain responsibilities, and I had to spend time in the lab. Last year I was doing a research project and continuing to follow patients in the outpatient, but we didn't have responsibilities on the floor. So what I would do is, if I needed to go back to the lab to finish some work, I would come home for dinner, and so I had time with the kids, and then I'd go back and spend a few hours in the evening, in the research lab.
Mm-hmm.
When I came up to Boston, I took a position at the Lemuel Shattuck Hospital, and again, this is where Dr. Fishman again came into the picture. He was doing some research with the Lemuel Shattuck Hospital, and so he was very interested in having a clinical person who was interested in his research efforts. And it was actually at the Lemuel Shattuck that we took care of that patient with the lung cancer that turned out to supply us with tissue that proved beyond a doubt that it was that the tumor was producing the alkaline phosphatase.
Mm-hmm.
At any rate, at the Lemuel Shattuck, again, it's interesting to look back on the things that influence your career. The Lemuel Shattuck Hospital is a chronic disease hospital, and at the time I was there, it was run by the state, and the chief of medicine there was, his name was Tom Chalmers, and he was one of the people who really made a point of trying to answer medical questions by controlled clinical trials. And at that time, that was not fashionable.
Right.
But he made that a crusade of his. And the interesting thing is that one of the first cooperative groups was the Eastern Cooperative Oncology Group. And that group was formed by a group of physicians, including Tom Chalmers. Even though he was not an oncologist, he was a hepatologist. But he applied the controlled clinical trial to, for instance, the whole question of the best way to treat bleeding varices, in cirrhotics, etc. And he made it a real point that when he would go on rounds, or he would challenge people about, how do you know that this is the best treatment?
Mm-hmm.
So he again, that was something that really got me going in the area of clinical trials, which I did for the rest of my career. He's, again, one of the people that I think really influenced the way I practiced medicine and clinical research that I did.
Mm-hmm.
In terms of lab research, I was strongly influenced, as I mentioned, by Bill Fishman. And when we get into the next stage of my career, out at Pondville, again, I was working with Fishman's Lab, and we also were the home base at that time for clinical trials for all of Tufts. And we were doing clinical trials through the ECOG and NSABP, and I was the principal investigator on that at the time. And we actually ended up with a coalition of 11 hospitals that where we carried out clinical trials according to those two clinical trial groups.
So we're talking about this, right now you're in the 60s, correct?
Yeah, I came up in 1964.
Right.
I went out to Pondville Hospital, which at that time was a state cancer hospital.
Mm-hmm.
It unfortunately is no more.
Mm-hmm.
But and I was the first full-time chief of medicine at Pondville.
So
So
how
that was
about
in
outside of medicine here? Because a lot of stuff is swirling around in the 60s. You have Kennedy's assassination, which, you know, being from Boston probably had a little more impact than the rest of the
Yeah, I
country.
actually was in Cleveland
When that happened?
when that happened, and it's as clear as a bell in my mind when I first heard about it.
And then the uproar of the 60s and everything, did any of that affect you in the medical field? Were there any influences with regard to how it affected medical education or just society in general?
Well, I know that it affected me in terms of I was strongly against the Vietnam War.
Mm-hmm.
I was involved in demonstrations in the 60s, anti-Vietnam. It affected my political thinking. We were strong supporters of Father Robert Drinan,
Mm-hmm.
and it affected my children, and I'm sure some of this rubbed off on them. My daughter, when she was at Yale, was demonstrating against the people who, in support of the people who were refusing to register for the draft. And she once demonstrated down in New London at the nuclear submarine facility and so on. So but in terms of the work that I did, let me put it this way. Medicare came in at that time.
Right.
I certainly was a strong supporter
Sure.
of Medicare. And when you think about it, you know, the idea that was a product of Lyndon Johnson, who he was able to get things done. And to me, it was just amazing, you know, that Medicare was passed. And even though the AMA at that time was strongly against Medicare, it was the best thing that could happen to physicians, because they suddenly were getting paid in cash instead of in chickens or products.
So what transitions, so pre-Medicare and Medicaid versus post-Medicare and Medicaid, what difference did you see in healthcare delivery?
Well, there were a lot of indigent people, and the two hospitals that I worked at had a fairly high percentage of indigents.
Mm-hmm.
And it was a situation where you really saw the haves and the have-nots.
Mm-hmm.
And I feel very strongly that health care is a right. It isn't a privilege. But our system hasn't recognized that adequately. I think in Massachusetts we've done better than other parts of the country.
Okay. And just to get back to the practice a little bit more, during that era, what sort of tumors did you treat? What were the most common? What sort of success rates? What sort of morbidity was associated with your treatment?
Well, the interesting thing is that Pondville Hospital was actually one of the places where some of the radical surgeries were developed. And we had a staff of visiting surgeons who many of them were based at the Massachusetts General Hospital. And when they sort of developed some of the surgery out there that they probably couldn't do at the Mass General. And they had more freedom to do things that were at that time considered somewhat experimental. But they were doing very radical surgery in terms of head and neck cancers, GYN cancers, the radical mastectomies. But I had the privilege of working with the NSABP, National Surgical Adjuvant Breast Program, that Bernie Fisher was the head of at that time. And they were the first ones to show that simple mastectomy plus radiation was as good as radical mastectomy.
Now, was that in the 60s or the 70s?
That was in the 70s.
Yeah. And
it was late 60s, early 70s. And what actually, they also did the first adjuvant studies, where they were using an alkylating agent, Alkeran, for the post-operative treatment of women with breast cancer.
now, what about cancer of the cervix? Did you see much cancer of the cervix in the 1960s?
Actually, I would not have seen it except for an occasional case. We actually had one of the pioneers in the treatment of the cancer of the uterus in terms of Rita Kelly. She was one of them. She would come out for our clinics, and she developed the treatment of Provera for cancer of the uterus. As far as cancer of the cervix, we really didn't have chemotherapy at that time for cancer of the cervix. And
So it's basically surgical and radiation.
it was surgical and radiation. Yeah.
Okay.
And in terms of the kinds of tumors that we treated, there were a lot of breast cancers, quite a few lung cancers. And in terms of breast cancer, actually, I neglected to mention one of the other clinical trials groups that we participated in, and Rita Kelly was very instrumental in that. There was a cooperative breast group. The head of that was Lou Segaloff, and he's one of the people who showed the value of androgens in people who failed. At that time, you know, we were treating patients with high-dose estrogen. We were treating patients with androgens. I mean, this was the dark ages of that, but it was effective, you know. They were treating, those are the early days when they were treating prostate cancer with estrogen, high-dose estrogen.
What kind of survivals were you getting for breast cancer?
You know, in terms of, are you thinking in terms of treating metastatic disease? Yeah. Metastatic disease was poor, no doubt about it. But you know, during that period of time, it improved, and little by little.
So in the 60s, if you had metastatic breast cancer, what would be an example of a 5-year survival rate?
With metastatic disease,
Yeah.
it was probably 3 or 4 years.
Okay.
But you know, the interesting thing was that I had some patients who I took care of at Pondville Hospital who, even after I left there, when I was at Pondville from 1970 to 1981. I then was recruited by a group in Ottawa, in Canada, where they were participants in both of those clinical trials groups, and that's how I knew these people, and I took on the position of the chief of medical oncology up there. But during that period of time that I was at Pondville, there was definite progress in the treatment. In the early days, it was mainly hormone treatment. And actually, we participated in one of the early studies of tamoxifen. And it was a dose-response trial. And that was through that, the cooperative breast group. And then we participated, you know, as I say, in the breast trials that the NSABP was doing. And ECOG had their own breast trials, so that you could see gradual improvement
with the chemotherapy.
in the response.
So let me ask you, I'm going to move you back and forth because you've been involved in so many different things. So I'm going to move you back and forth a little bit. Now, you spent some time in Ottawa in the early 80s, and were exposed to a different healthcare system there.
Correct.
Give me a sense as to what your impressions were on the inside of the healthcare system in Ottawa.
Patients got very good care in Canada. We were able to, everybody was covered by health insurance. The interesting thing in terms of the present political climate is that in Canada we had a system that covered everyone, and it wasn't called single payer, it was called Medicare. Which is very interesting. The other interesting aspect of it is that it started in one province. It started in the Saskatchewan, and then it spread to the other provinces, and it eventually became a federal program. And that's why I'd like to draw that analogy in terms of the fact that right now, I think with the divisiveness in Congress, there's no way that we're going to get single payer, or what I call Medicare for all, through on a national basis. But Vermont has passed it. Massachusetts, I think, will eventually pass it. And we've got a situation where we have to make it a human right. The fact that we have somewhere between 45 and 50 million people in this country that are not covered, that don't have insurance, is just not right. And Obamacare is a step in that direction, but it still leaves the control to the insurance companies. And it doesn't make sense. We pay twice as much as any other country in the world for health care on a per capita basis. And depending on what statistics you use, we're not getting our money's worth, because we're something like 29th in the world in terms of some of the important measures such as longevity and maternal death and childhood death.
Now, the Canadian system, I don't know a lot about it, but my understanding is that there's a national standard, but there are individual versions in each province.
That's correct.
Not unlike our Medicaid system in this country, which is run with a similar principle.
Right. But, you know, patients get much better service than what we have in this country in terms of patients who are on Medicaid. And it isn't one of these situations where on Medicaid, you know, the providers end up getting 60 or 70 cents on the dollar, which just is not appropriate. So I know there are a lot of people who say we've got to do this incrementally. What I tell people is we've been doing it incrementally for the last 60 years, and we're worse off now than we were 60 years ago.
Okay.
And then I quote an eminent British politician, David Lloyd George, who said that you cannot cross a chasm in 2 steps. So I'm for doing it now.
That's very clever. So let me now swing you back to the medical part of your
Sure.
career. And you spent the 70s in Boston. You started off the 80s in Ottawa. And then after being there for a period of time, decided to return to the United States. Right. And so now we're into the early 80s or so. And you came to Boston.
Well, I wasn't
Okay.
before.
Right. You came back to
Yeah,
Boston.
back to Boston.
Mm-hmm.
Yeah. So, anyway, when when I came back to Boston, it was with the idea that I was going to continue in the area of medical oncology,
Mm-hmm.
but I also was interested in further developing my interest in what I call the psychosocial,
Mm-hmm.
the biopsychosocial model. And before I left for Canada, I had been approached by someone, a woman by the name of Joan Borisenko, who worked with Dr. Herbert Benson, who developed the idea of the relaxation response. She at that time was interested in doing a project of developing a group for melanoma patients and studying what the effect on their longevity and so on would be. And at that time I was just about ready, I knew that I was going to be leaving because the hospital had been sold to Norwood Hospital, Pondville Hospital was
Mm-hmm.
sold to Norwood. And I knew that if I stayed, my academic affiliations would be different and I wouldn't be able to continue the work that I had been doing. But anyway, so I told Joan that I was fascinated by her ideas, but that this wasn't a good time. But if I came back, I certainly would do it. So when I decided to come back, I had already become quite interested in some work that Bernie Siegel was doing down in New Haven. He had a group called Exceptional ECAP, which stood for Exceptional Cancer Patient, and I thought that that was an interesting model. I'd gotten to know Bernie Siegel. I heard him speak a few times. And when I came back, I approached Joan about the idea of setting up a mind-body program for cancer patients. And we eventually got the funding to support that work. And so I worked with Dr. Benson in '85. I actually spent a year at BU, and I was at the VA and at University Hospital in their oncology department. I, during that time, was developing the plans and waiting for the funding to come so that I could join Benson full-time. And then Benson moved to the Deaconess Hospital, and I was half-time medical oncology and half-time behavioral medicine. So at one point or another, I've actually been affiliated with all 4 of the medical schools.
Wow.
Here. And we found that this mind-body approach was very beneficial to patients. And we would measure the psychological effects, etc., on the patients. But the thing that was most impressive, the thing that I still find not amazing, but impressive, and is the ability of patients to make major attitudinal shifts in how they dealt with their disease. And when people would ask me, what do you do in these groups? Well, give me a summary, I would say, the patients would come in seeing the glass as half empty, and 8 weeks later, they would see the glass as half full. So there was a lot of, it wasn't just meditation, it was cognitive restructuring in terms of how people see
Mm-hmm.
their disease and their stresses and so on.
Hmm. Wow. And then at some point you decided to come to Worcester.
Yeah.
And what made you move to Worcester?
Well, I, again, I was, there was an ad that the Fallon Clinic had. I knew that John Kabat-Zinn, who is, the guru of mindfulness meditation, was here. And so I answered the ad. I came out and I was interviewed by two of the oncologists at the Fallon, and I asked them an important question for me. I said, how much time do you give for a new patient appointment, and how much time do you give for a follow-up appointment? And the answer was 20 to 30 minutes for a new patient and 15 to 20 for a follow-up. And I said, I was very interested in this position, but I can't work under those circumstances. I cannot take care of patients in that with those kinds of time limits. So they said, well, there happens to be a position at St. Vincent Hospital. They need a new chief. So I said, well, maybe I'll apply for that. And I did.
Mm-hmm.
And Gil Levinson, who was the chief of medicine at that time, he took me on. And I had a fruitful number of years, from 91 to 98. And we continued to participate in clinical trials. I loved the opportunity to teach and to medical students, residents. That's one of the things that actually I haven't had a chance to talk about, is that I've always really enjoyed teaching, and not so much didactic teaching, but teaching by example. And one of the things that I feel really quite proud of is the fact that when I was at Pondville Hospital, we had an oncology training program that involved Lemuel Shattuck Hospital, the Pondville Hospital, and New England Medical Center. And we had the fellows were rotating through all three hospitals.
Mm-hmm.
And the interesting thing is that many of the our trainees ended up going into practice in the greater Boston area and setting up oncology programs at a number of the community hospitals.
Mm-hmm.
And that, to me, was really very, very satisfying.
Mm-hmm.
And as I mentioned, the clinical trials program we had in 11 different hospitals,
Wow.
including Worcester City Hospital. And we had some people rotating down from there, coming down to Pondville to help us run some of the clinics.
So in the 90s, what were the most common cancers that you treated? What sorts of treatments did you use? What sorts of success rates did you
At one
achieve?
point, I was very interested in renal carcinoma and melanoma, because these were two tumors that seemed to have some immunological effect. You got spontaneous remissions, even though there weren't very many. Those are two where there were spontaneous remissions. So I was interested in those. The mainstay, I would say, was still breast cancer and breast cancer and lung cancer, because those are the most common. Prostate cancer, I certainly treated a lot of those. GI tumors, colon cancer mainly. We participate in clinical trials in colon cancer, both in advanced disease and in adjuvant studies, because the NSABP became breast and bowel, so we were involved in adjuvant studies there.
What sort of results, what sort of 5-year survivals with metastatic disease would you find?
Well, again, in colon cancer, unfortunately, it would be probably, 20 to 30% response rates. And once they had metastatic disease, you could, you knew that they didn't have that much time. Even in breast cancer, and there are very few patients with metastatic disease who survive,
And what in your mind over your career were the biggest advances in chemotherapy?
Well, I think that the sad thing is that the best results were in rare tumors. Could we turn off for a minute? Because
All right.
in terms of the treatment of cancer, the major change that has occurred, and some of this is more recent, is that therapy is becoming more and more targeted in terms of drugs being developed aimed at the specific defect in a certain kind of cancer.
Mm-hmm.
And that's, to me, is really a major change, and it's going to take a while. When people think of that there's going to be some magic bullet that's going to get rid of all cancer, and it's hard for people to understand that each type of cancer is different, and that each type of cancer has an entire spectrum of defects and response to certain therapies. And that what has come out, the information we now have, is that you can save patients from getting treatment that isn't going to work.
Mm-hmm.
And if you are able to select your patients, you may get an 80% response rate for a subgroup of patients, when the overall response rate is only 20% or 30%.
Mm-hmm.
So that's something that I think that's a major advance. The other thing is that there are a number of cancers that are still quite resistant to therapy. One of those is lung cancer, for instance. And, I'm fascinated by some of the discussions that go on at meetings where they're talking about, we've got we have a statistically significant result. We've increased the median survival by 6 weeks, but it's statistically significant. I heard those things in the 80s when I was the chairman of the lung committee for the ECOG.
Mm-hmm.
And, you look at the results now, and they're practically the same as we had in the 80s. So that we haven't made the major breakthroughs.
Mm-hmm.
And, a lot of our advances have been, in terms of decreased mortality, are in colon cancer, because we are able to take out polyps before they become malignant. In cervical cancer, you've got the pap smear, you now have the vaccine. Those are major advances.
Mm-hmm.
But treating the disease once it's advanced, the results are still poor.
That's a good, yeah.
And so we've got a long ways to go. And as I mentioned, there isn't going to be a magic bullet, but there are going to be a lot of bullets, and we have to take a look at the various aspects of the armamentarium.
Mm-hmm.
that is available.
And then you've retired from clinical practice in 1998,
Yes,
but you still remain active.
yes.
And so what sorts of things have you done post-retirement?
Well, I'm, as we talked before, I'm still pushing for single payer, or as we call it, Medicare for all for Massachusetts. We've had a single payer bill in the legislature for the last 18 years. This is with an organization that I work with called Mass Care. And unfortunately, the bill has never gotten out of committee. But we're continuing to push, and there's an interesting bill that we have in addition to our single payer or Medicare for all bill. And that's one that is going to take a look at the cost of health care under the last bill that was passed, which was the cost containment bill. And one of the requirements of that bill is that they track the cost and whether there's going to be a decrease in the actual cost of health care. This bill that we've been involved with says that not only do they have to track the cost, but they also will need to track what it would have cost if we had a single payer system.
Mm-hmm.
And if that shows a significant decrease in the overall cost, then the legislature would have to at least look at the possibility of single payer for Massachusetts. So that's something that we've been working on. And we have a resolution that we've sent in to the Mass Medical Society to try to get their support.
And you've also worked with medical students.
Yes. That's been something that I've, again, feel that was one of my accomplishments, that I was able to serve as a mentor to the medical students. I've been teaching, I've been a preceptor in a course for first and second year medical students at UMass Medical School, and it's on end-of-life issues. The course has been in existence for the last 16 years. It's an elective, and I feel it should be required rather than an elective. But the students seem to get a lot out of it when we look at their responses about, the benefits. I always have enjoyed teaching medical students, and when they're on service with us, we at UMass, we've got their medical students at St. Vincent's, and a number of them ended up going into oncology after their rotation with us. Again, I feel that that's
on your cap.
yeah, it's something that I feel good about.
Mm-hmm.
And the other thing is that we not only had the opportunity to teach medical students, we also had opportunity to teach physician assistant students at Palmville. When we taught nurses in terms of, we trained some of the first oncology nurses. When I went out to Palmville, we mixed our own drugs and we injected our own drugs. There was no such thing as an oncology nurse, which seems, when you look at it now, you say, those were the dark ages. But we actually did our own mixing. We didn't have a hood, which is not something that's recommended.
Right.
And, but I still see some of the oncology nurses that we train.
Mm-hmm.
And the physician's assistance program at Northeastern had Palmville as one of its rotations.
Excellent.
So I've had a chance to really be involved in teaching. And, to me, the most important aspect of the teaching is, as I said, it's teaching by example. It's teaching people how to take care of patients, take care of the whole patient.
Mm-hmm.
And when you ask me about some of the major changes that have occurred, one of the important areas is development of hospice. When I worked at the Lemuel Shattuck Hospital, the head of the oncology division there was a fellow by the name of Mel Crand. And he actually brought hospice to the United States. He brought Cecily Saunders, who developed the hospice movement in England, to the United States. And he sponsored her speaking in the Boston area. And then he went out to UMass and became the head of a palliative care service, which was an inpatient service. The irony of it is that after Mel left, that became the bone marrow transplant unit for the hospital.
Wow.
And they did away with the palliative care unit.
Yeah.
And now I'm glad to say that palliative care is something that has been developed and is doing a lot of good for patients.
Wow.
And the palliative care people are actually the ones who are co-leading this course on end-of-life issues with David Clive, who's a nephrologist.
Wow. Remarkable, remarkable career. I listened to you, and you started in oncology with the birth of the specialty when it was just started.
That's right.
You then branched out into issues regarding behavioral medicine and worked with Herb Benson, who again is a pioneer in that field. Yeah. You've expanded into the hospice movement. You've moved over into politics and dealing with healthcare delivery, and looked at every aspect and remain active even in your retirement.
Yeah.
This was a wonderful interview, and
Yeah.
I thank you so much for taking time to speak with us.